if I want to go for the recipe of success in immediate implantation, I have to remind you with the story of Thomas Edison. Thomas Edison, he was working with the 2,000 filaments to invent his bulb. And he failed with the 2,000 experiments. So his assistant got sick of him and said, I want to leave you, because failure after failure after failure, and we learned nothing. But Thomas Edison insisted that we learned a lot of things. One of them, that those 2,000 elements, they don't go well for the electric bulb. It didn't take him more than 3 months to invent his bulb after 2,000 failures and experiments. And he kept the patency for his name without his assistant. It's very similar. Immediate implantation, we've been through a lot of failures. There were a lot of myths and reality that we've gone through our practice. So to be very clear, I go back 25 years, a retrospective review of my cases, okay? With 25 years, a review, a retrospective study of all the literature. I will try to make it like a woman's skirt. Maybe it's long enough to cover the subject, but short enough to create interest. So I hope that my presentation will be of your interest. Of course, all my presentation is from my private practice and from the literature. I have no any commercial relation with anybody, and all the cases are from my slides. Well, to go to history a little bit, immediate implantation started with Professor Schulte as old as the mid-70s, in 1976. You see that he's practicing even without wearing gloves. At that time, we didn't wear gloves at that time. Yeah. And he invented his technique using a ceramic implant. It was called Freilet 1. And the patient kept this implantation immediately for a long, long time. Now, all the literature afterwards by Schulte, by Yuli Grunder, says that, well, immediate implantation has the same success rate, but we've got to use a special implant, which is the entire cross-section of the socket should be filled with the implant. We have to use wide diameter implant, and that's why they made a special design for those kind of immediate implantation. This is history. Maurice Salama and David Garber, they recommended in 2001 to use wide diameter fixtures to place as immediate implantation. We should go a little bit into history. Paolo Antonio said, wow, what's great in immediate implantation is that if you place your implant immediately, you'll get no resorption in your socket. And this is very important. You will maintain the bone and the soft tissue. So to avoid all the negative effect of bone loss. This is the major concept of immediate implantation. They told us that we have a 97% of survival rate. Wow, that's great. Even a lot of studies in the early 2000s, if you get the primary stability, you'll get the 4 years, after 4 years study, you have a 98% success, which is excellent. Now, what do we need more? Survival rate, very high, 98%, success, less treatment time, and bone tissue preservation. Do you want more in your practice? No, I don't want more. So I started to do my immediate implantation as early as 2004. But you have to be very careful to do atraumatic extraction, and this is a must. Well, going back to my first cases, this one in 2003, unrestorable tooth, atraumatic extraction. I placed my implant according to the protocol, and you can see 3 months later, what a good soft tissue I have. I'm so proud of my work. But if you take a very close look at the final prosthetic work, you see that I lost about 1.5 millimeters, and I had to cover it with a pink porcelain. Well, I followed all the protocol, but I had a failure. I had the recession for 2 millimeters. Then, this is my second case. I was so happy with this patient. She came to me, she needed 6 implants. I'm so happy with her. So I offered to place it immediately. I placed my implants. I was happy after 3 months. The patient was so happy. But 2 years later, what did I get? If you look at the implant in the place of 21, exudation, pus, and I lost the implant. Why in 2 years? So I start to ask myself, why did I lose the bone around this implant? The only reference at that time that I had was the Bible of implantology, Carl Misch. And he said that maybe it's because of the zipper effect when I am placing the implant. This is the first, and I was wondering, do really immediate implantation prevent bone resorption? That was my question. Of course, the answer is no. Even if you place the implant. And this came very quickly. Just in 2005, Arujo and Linda said that bone resorption and gingival recession is not avoidable, even if I place my implant immediately. So, the first myth had been taken out. Even Van der Wijan said that if we are using wide diameter implants, we are getting about 4 millimeter loss of bone, even if we place our implant immediately. So, the first myth that immediate implants is described to avoid the negative effect of extraction has dropped down. The reality is bone resorption is something non-avoidable. So we have to take actions against those resorption. Even John Linda in 2004 said that we can lose horizontally about 56% of the bone in the first 6 months. So how can we avoid it? And we started at that time in 2004 to ask ourselves, do really immediate implantation enhance bone resorption? We were thinking even it will increase the bone resorption and we may stop doing immediate implantation. Then, the answer came so quickly. And how about the aesthetic outcome after immediate implantation? You have seen some failures. The answer came in 2005 from the master of implantology, the master, Danny Boozer. Danny Boozer said, if we place our implant touching the buccal bone, then we will get a resorption, definitely. So we stayed placing our implants from 2002 until 2005, then we understood why this resorption happens. And he put a protocol how to place the implant according to the labial bone and to others. Then, at that time, I went back to my case that I showed you before. I went to the surgery, and excuse me for the picture at that time, we didn't have very good cameras at that time. Okay? So, if you take at the surgery, take a very good look at all the implants. They were accidentally placed in a palatal direction, except this implant. It was touching the bone. And that's why I got the resorption. If I placed it a little bit palatally, I would have avoided this kind of resorption. The same implant that I showed you before with a recession of 2 millimeters, if I placed it in a more palatal, I would have. But now the question, do we place narrow implants or wide implants? What do you think? Would you place a narrow or a wide implant? Wide implant.
Narrow.
Narrow implant, okay. Let's see the literature. Let's see the literature. The literature says placing wider implants will increase the bone resorption. So now we are heading, so all the myth of using wide implants had gone, resorption is more. So wide implants should be used. This was the myth, but the fact, wider implants will cause more bone resorption, especially in the aesthetic zone. But at that time, in 2005, we were using wide diameter implants.
Don't touch this part?
Yes. And I will show you now in the workshop how to place your implant correctly in immediate implantation. Of course, they used to say that, okay, at that time, we were using wider implants with a contact with the bone, and at that time, we didn't have a switching platform designs, right? And we were reflecting a flap. Oh, now comes the question. They blamed reflecting a flap is the cause of the bone resorption in the buccal plate, which is logic, right? Because the labial bone may lose some of the blood supply because you are reflecting the periosteum, right? Actually, they started in 2005 to encourage us to do flapless surgery in immediate implantation in the aesthetic zone. And Joseph Kahn said that, oh, the recession rate, if we raise a flap, is about 43%, while without a flap, it's only 7%. So they had to encourage us to do immediate implantation flapless. All the studies showed that if we raise a flap, we will get more recession. If we make it flapless, less recession. That was in 2005. Please follow me exactly how to do it. Then, so I started to do flapless surgeries. This is one of the first cases that I did it flapless. The patient came missing lateral and central. So I had atraumatic extraction, placed my surgical guide, simple surgical guide at that time, placed my implant, and you can see that I placed them a little bit palatally, as they recommended. Very nice soft tissues. The healing was uneventful in 3 months. The patient was happy, and I was happy that I invented this in 3 months. But take a look. I had black triangles. Well, what all those promises that Paulo Antonio Yoli Grunder said that if you place the implant, you will not get loss of the soft tissue. Now I lost the papilla. Why? So we started to make few steps back from immediate implantation. Until 2007. In 2007, Maurice Salloum and David Garber published a paper which is very important, that is showing us the exact way how to place our implants. The ideal position, the acceptable position, and the wrong position. So we were placing in the wrong position before that. And according to Salata and et al., we have to insert our implant 1 millimeter deeper than the level of the buccal crest, first, and at least 2 millimeters away from our buccal bone plate. Well, that's what we're doing now. And according to Tomasi, what should we do? So the first drill has to be done in a 35 degrees or to 40 degrees angle. toward the palatal bone. After inserting into the palatal bone with this direction, then we move our drill parallel to the to the palatal side. So our first drill has to be penetrating in a 35 degrees angle. After penetrating for 5 millimeters, we shift and then we go parallel. And this is...
With the same drill?
Yes, with the same drill. After you go inside, you take it back and do it. We will see it now. And according to the shape of the alveolar bone, there were several classifications. So on your CBCT, you can determine the shape of your alveolar bone and then decide the way how you should drill in a way to keep your final implant away 2 millimeters from the buccal plate. You want to take a photo of this? Yes, sure. Take a photo of this one too. So, as I stressed that the first has to be taken at 35 degrees and then taken parallel to the palatal bone. Okay? Now, I've learned the lesson. I go on a palatal, keeping a distance between 2 to 3 millimeters. This is the drill. So I keep at least 2 millimeters away from the buccal bone. I place my implant, the narrower implant, no more than 3.75, okay? Never more. And this is the way that I should place the implant. 2 millimeter deep, 2 to 3 millimeter away from the buccal plate. Why? No, I'll come later. Why do we place 3 millimeter, 2 to 3 millimeter deep? Because biology. We need those 3 millimeter to the biological width to be created so we can create a good emergence profile. That's why if we don't follow the rules, we'll get into real aesthetic risk. Thank you. But we are away 2 millimeter of the buccal plate. But the research said that even if the buccal plate was thin, less than 1 millimeter, we will get more bone resorption. But how often do we get a 1 millimeter buccal plate? What do you think? What do you think that the thickness of the buccal plate that you have? What do you think? The thickness of the buccal plate usually? 2 millimeter?
No, less.
Less. How much you think?
Less than 1.
Less. That's true. In the research, if you have a buccal plate less than 1 millimeter, you'll get more bone loss. Even if you place your implant 3 millimeter palatally. What is the thickness of the buccal plate? We didn't know before the CBCT. Okay? In the research, if you see that, after CBCT measuring, 40% of the buccal plates are 0.5 millimeter. 30% are 1 millimeter. So 70% of our cases, we have a buccal plate less than 1 millimeter. What should we do? 70% of our cases, this buccal plate will resorb. Do you know why? Whatever you do, this buccal plate will go into bone remodeling and will disappear. Anybody have an idea why? No. Because simply, it's not a mature bone. It's a different kind of bone. It's called bundle bone. And the bundle bone will tend to resorb. The bundle bone, it's a kind of combination, is referred bundles of principal fibers, either from the periosteum or the PDL. It's not a spongious bone, it's not a cortical bone. You got it? So it's not a cortical bone and it's not a spongious bone. It's a special bone which is only in the buccal plate. This will resolve definitely. And why? What do you think that the blood supply, if you remember in 2005, they said that start doing flapless, because if you raise a flap, you will harm the blood supply of the buccal plate. So we think that maybe our blood supply comes from the periosteum or from the trabecular bone or from the PDL. The study showed that the blood supply of the buccal plate comes from the PDL. That's why when we do the extraction, all the PDL is gone. So all the blood supply to the buccal plate, which is the bundle bone, is totally lost. That's why the buccal plate is resolved. So even if we place our implant in a 3 millimeter away from the buccal plate, we will end up in a good osseointegration of the implant, because 3 millimeter is enough to create bone that covers the thread of the implant. But we have an aesthetic problem. We have a gum loss, and still we have a bone loss. So now the research came. They said that if you do it flap or flapless, there is no difference. There is no difference. Doing a flap or a flapless doesn't make a significant, it makes a little difference, but it doesn't have a significant difference between the two groups. Okay? So the fact now, the myth that flapless surgery will maintain the bone and the tissues has fallen down. Raising a flap has no significant, it has a small effect, but not a significant effect in losing the bone and the soft tissues. That will explain, and that will explain, if we do the extraction, you see that we lose the bone here, and that's why the interproximal bone is kept. Why? Because this bone, the bundle bone, is getting its blood supply from the PDL of the adjacent tooth. This is how we maintain the papilla. After this understanding, just imagine, Dentist Arnaud, a lot of you maybe have read articles for Dentist Arnaud. He said that if you keep a distance between the implant and the adjacent tooth, 1.5 millimeter, you will get a recession up to 2 millimeters. If you keep 2 millimeters, you keep 97% of the bone. Half a millimeter makes so much difference in the aesthetic zone. And he made a protocol that a minimum of a 1.5 millimeter should be kept, because we need actually more bone and less titanium. If you approach the interproximal bone, they will lose part of it. Yes, sure. And you know, from the morning, I don't know how many attended this morning with the Agnini brothers. They showed us also this article by Dennis Sarno and Maurice Salama. If you place your implant shallow enough so the distance between the bone and the contact point of your crown, if it's 5 millimeter, you'll get the papilla. 90% you get the papilla. If the distance is 6 millimeter, the percentage drops down to 56. 1 millimeter will lessen, I repeat that. If the distance between the bone and the contact point is 5 millimeter, 98% you will preserve the papilla. If it's 6 millimeter, 1 millimeter, it will drop to 56%. If it's 7 millimeter, it will drop into 27%. So we lose the dental papilla. And the distance between the two implants should be at least 3 millimeter to maintain the bone and the papilla in between those two implants. Now, after reading those articles, I'll get you back to my case, which I showed you I lost the dental papilla. I should have placed them deeper and little bit wide. In that case, I would have maintained the That was my mistake at that time, but we didn't know this. What shall I do to solve this case? The implants are already osseointegrated. Now we realized that after the designs of platform switching, the 3 millimeter should be between the platform of those two implants. Okay? What I did, I started in 2006. Don't worry. What I did, I took the crowns out. I changed the abutment into the concept of switching platform. So I changed the abutments for smaller size. Now, when I made it smaller, I gained a 0.5 millimeter more. So I got the 3 millimeter between the two implants. And I started to fabricate new temporaries and start to pray, God, please help me to get the papilla back again. God, please help me to get the papilla again. So, and that's what we called creeping papilla. Just leave Mother Nature to take its place. Yes, all those are temporaries. In 2011, so it took me 5 years to get back all the papillas. Changing the temporaries until I got the creeping papilla. So it took me from 2006, this is 2011, look at the difference. I just changed the abutments to a switching platform concept and let the Mother Nature biology work by itself. But I wouldn't have think of this solution without reading the articles of Dennis Sarno.
Why you are doing the temporary one?
No, because you have to adjust those temporaries several times during. In 2014, I remember when I was with Maurice Salama at one of the congresses, he said that solving the central lateral dilemma, never put two implants. One implant and one pontic, because it's very rare that we have enough space. Leaving 1.5 millimeter from the adjacent tooth, leaving 1.5 and 3 millimeter between your two implants. You must have a very wide, and this rarely occurs. So the best way is to place one implant and one pontic. Now we have to go back. This is a case that I had, like your case here, 7.5 millimeter width of my socket. But I placed a 3.75 millimeter diameter reader implant with the exact three-dimensional positioning of my implant. Well, I know that you will ask me, but what about the gap? Do I leave the gap? What do you think? What should I do? Do we leave the gap? We have a gap. And we are taking our primary stability from the apical third of the implant. We shouldn't get our primary stability from contacting the walls. Okay? This is a principle. What about the gap? I have 3 millimeter gap. What do you think? Do you have any idea? What should we do with this? Well, Dennis Sarno said, if we leave the gap, it will heal. And you will get bone in 9 weeks. It will be closed with bone contacting your implant by itself. This is Mother Nature. It's just like healing the socket after extraction. You will get the bone. Yes? No, never close. And I will show you now why not close. What?
Why not do you bone graft?
Why do we graft? As long as we, after 9 weeks, we get a remodeling. Why? The answer comes. First, we have to know, why did we get bone? How did you get bone? Wait. Just follow me step by step. Why did you get bone? Why we got bone in this gap area? Without closing, without closing.
I don't think so.
Without closing. Without closing what? Even if you close, you will close. You cannot close all the wound tight after immediate extraction.
You can make a flap and close.
No, never do a flat. I'll show you now why. Why do we get the bone here in the gap? Because the blood clot is here. And the blood clot is a dead body.
Yeah.
Is a dead body. And why do we get bone? We don't get epithelial tissue. Because in dead bodies, the epithelial tissues will not grow in dead bodies. That's why if you close it, you will give more chance for the epithelial cells to go inside, okay? So this place, no epithelial cells coming inside, so no soft tissues. The only tissue that is allowed to grow here is the bone. Then, why do we graft? It's recommended to put a graft material. Why? Because filling the gap, sorry, even, why to graft? Because filling the gap will minimize the socket collapse. Mother Nature will go on remodeling. The bundle bone will resorb. But placing a graft between the buccal plate and the implant will minimize. It will not stop, but it will minimize the socket collapse. And that's what we want for aesthetic effects, okay? That's why the gap, we fill it with any graft material of your choice. I don't want to go now into what kind of graft material you use, allograft or xenograft, whatsoever. This is a totally very separate issue. But we always graft the gap to minimize the socket collapse. So we fill with the graft material, and the most important, don't close, protect this area either with the temporary crown, if you are able to temporize, if you have an initial stability more than 35 to 40 Newton centimeters, or you have an QSI of 70 or higher, you can put your temporary crown. Otherwise, you should use a temporary customized healing abutment to cover the area, to protect your bone graft material, and to make a block over it, and let Mother Nature do its job. It will heal, and you will find all the bone intact. After 4 months, you'll see the healing process. 3 to 4 months, you can put your final restoration. Look at the socket. This is day 0 at the delivery, and this is 3 years post-op. Extremely minor changes in the contour. So I maintained somehow the bone and the soft tissue. You agree? Now, Maurice Salloum and his team has gone furthermore a little bit. He said, not only graft the gap, how about if we fill the graft material up to the level of the soft tissues? Not only fill the gap to the bone, extend your graft material to the top of the soft tissues. And this is called the dual zone therapeutic concept. This is one of my cases that I learned from Maurice. In 2014, we started to use the dual zone concept. It's the same concept, but the graft material, you see that it is up to the level of the soft tissues. It's not only filling the gap, it extends up to the soft tissues. And 24 hours later, I placed my temporary crowns. Always place a temporary if you can. And you can see 4 months later, you can demonstrate that there are some residues of the graft material that I used integrated in the soft tissues. Don't touch it. Just leave it. Just leave it. 2 years later, you see that maintained the same contour of the soft tissue and the hard tissue. So we all agree about this recipe. Agnini brothers, who were here in the morning, standing in my place, they taught me a technique that not only fill the gap, but also make a veneer grafting, like an overcorrection under the buccal plate, because there will be a remodeling. So if we want to stop or make a negative action against the remodeling a little bit, we have to do an over grafting. I'll show you my cases. How are the mistakes? Flapless, one abutment one time. So I place the final abutment, I place a temporary crown over it, place my overlay graft material with the membrane. You see? Clear? With the temporary crown. 4 months. 1.5 years. 3 years. The same contour almost stays the same. Now, then you start know, and Team Atlanta and Team New York made a special study. Placing an implant with a temporary, with a graft, or not. And they reached the same in 2005 in 2 sections. That placing a temporary is almost a must. This will maintain the contour of the soft tissues, and it's all published in the literature. The volumetric tissue changes can be minimized if a provisional is immediately connected. So connect always a provisional restoration. If you cannot do a temporization, make a custom-made healing abutment. This will preserve, okay? Actually, this is another case. I will show you 5 years that maintained the soft tissue contour after immediate implantation, grafting the gap, dual zone. So, immediate implantation means that you have to place in the aesthetic zone immediate temporization. Do we agree on that? Okay. Well, we all agreed that we had the buccal plate less than 1 millimeter, 1 millimeter. But how about if we don't have? Please have a seat. Are you okay? How about if we don't have a buccal plate? Do we do immediate implantation? I'm a hero surgeon. Yes, I can do it. And you'll see what I did. Because I'm a heroic surgeon. Of course, there are 3 classifications of the socket. Type 1, which we have bone and soft tissues, that we okay for immediate implantation. Type 2, that we still have the soft tissues, but we lost part of the buccal plate. In type 3, it's definitely non-indicated for immediate implantation. Type 2, they divided it into 3 subcategories, type 1A and B and C, according to the severity of the bone loss. Well, as they, in literature, said, if you lose part of the buccal plate, it's okay. You can place your bone graft material, place your membrane and graft material, and it will be okay. Said, okay, I'll do it. I do everything after I read the literature. So, this is one of my cases. It's exactly type 2B, which I lost 5 millimeters of the buccal plate. But I don't care. I'm a hero surgeon. I can do miracles with this. So I raised the flap, placed my implant in the correct positioning, 1 year follow-up, almost the same zenith line, 3-year follow-up, no changes, and the 5-year follow-up, almost no changes. Well, then this is predictable. So it gave me like a heroic reaction that I'm an excellent surgeon, I can do miracles. So what about of type 2C? There is no buccal plate. But still I insisted to do my immediate implantation. Okay? This is the case. You see, no buccal plates. I did my atraumatic extraction, placed my implant, placed all the graft material with the PRF, PRGF, whatever you want, all those cocktails that we mix. Placed my membrane, closed the wound, Wow, I was happy with the result. She's a friend of mine. She's the anesthesiologist that works with me in the hospital. She was happy. But if you just take her lip a little bit up, look at the results. I lost all the soft tissues. So no miracles. After 1 year, when I was Hennis Tarnot, we were at the conference, and Hennis Tarnot walked all the way, all the halls, said, no buccal plate, you have to answer no implant. Hello, sir, no buccal plate, no implant. Hello, sir, no buccal plate, no implant. If we have no buccal plate, don't do miracles. And I showed you how I failed with my miracle, because I was overconfident that I can do the bone grafting, whatever. And I succeeded with the bone grafting, everything. But the final aesthetic outcome was not so good. Well, we should go for early implant placement, which is 4 to 6 weeks, okay? Why? Because if we go for not delayed, but early implantation, we will get more soft tissues. If you let biology heal, you will get 7 times more soft tissues if you let the socket heal. Well, I follow the rules. Those are protocols. This is a patient I had, so I followed the protocol. I let the socket heal by its own. 6 weeks later, you see that there's no buccal plate, but I let the socket heal, so I get more soft tissue. Well, very clear, type 2C. Well, I used all techniques in my toolbox. Osseodensification, I used the PRF, I used all graft material. I used all what I have in my toolbox. I placed the titanium membrane, and I covered it with PRF, also with the collagen membrane. I placed a bonded temporary. A bonded temporary. It's like a Maryland bridge. Okay? See? Look, 4 months later, I took a CBCT. Look how much I gained bone. 4 millimeter, 5 millimeter. I was happy with the result. Oh my God, I'm a hero surgeon. I was so happy. But 20 months later, 1 year and a half, where's that bone gone? I had to collapse. Why? What do you think? Don't you believe that I followed the protocol exactly? I followed everything up to the norms. Because I didn't pay attention on the soft tissues. I didn't pay attention that I have a thin biotype soft tissues. If you don't have a thick biotype soft tissues over your bone graft, it will not maintain. So, there's a correlated relation between soft tissues and the bone. Even if you have good bone, if you don't have thick soft tissues over it, it will not be maintained. So I didn't pay attention. That's why I lost part of the bone. That's why Danny Boozer said additional surgical intervention may be necessary to enhance the surrounding soft tissues. And then David Garber, his famous phrase, the bone sets the tone, but the tissue is the issue. Even if you maintain the bone, if you don't preserve The tissue over the bone, you will lose it after 2 years. And that was my mistake at that time. Okay? So the fact that the myth that the bone is the main factor for maintaining the implant, the fact is that it's a correlation. The soft tissue properties is an important correlating factor. Even Howie Glockman, he said that even if you make an immediate or a little delayed or late implantation, sometimes if you have a thin biotype, you have to put a connective tissue graft. It's always that the evidence that if we don't place a connective tissue graft, it will be risky. So now the protocol, I told you, placing the implant in the 3D position, correct, adding a graft material. In selected cases where you have a thin biotype, you have to add a connective tissue graft. You see how much it became more complicated just to satisfy our patient from an aesthetical point of view? You know, you can take your graft from the tuberosity, from the tuberosity or from the palate. It's a simple procedure. This is a case that I did long time ago. And I had this kind of recession that I showed you. How did I solve it? Just a simple connective tissue that took me from this situation to this situation. You see how a piece of sushi can make a lot of difference? Just a piece of sushi. Until I met this guy. You know him? You know him? Ah. He's a brilliant guy that he got with an idea. According to biology, we saw that the bundle bone takes the blood supply from the PDL, right? So he found a way to maintain the PDL. We need to extract the tooth, but he made like a partial extraction, leaving the buccal part of the root intact with the labial bone. So he's just fooling the body that the tooth is still there and keeping the PDL with all the capillaries just to maintain the buccal plate. Of course, lots of study had been made on a histologic level, on an even clinical level. So it's called partial extraction therapy. It's a combination of root shield and tontic shield and the socket shield. The concept is we take part of the tooth, which is the palatal part, and we keep the labial part. This is the first case, I think, that I did with the socket shield. And I will show you now. Placing the implant in the correct 3D positioning, which is mandatory. Placing a graft material between the implant and the buccal plate. Here we place a graft material even between the implant and the shield. Okay? Place a temporary or customized healing abutment. Temporary. And you see, 12 months later, absolutely no recession or change in the buccal contour. Absolutely. After 3 years, everything is maintained the same contour. After 5 years, the same contour. This is a cemented crown that I always cement with the temporary cement material. So the patient came just because his crown has fallen down. So I took the picture. 5 years. Now, this is 9 years. This is taken last month. 9 years follow-up, the same contour. So when you can do the socket shield, don't hesitate to do it. Of course, there are a lot of literature, even multi-center studies that had been done by so many brilliant colleagues and friends, and they found, even on the histologic level, a bone touching the implant and the shield. So we got a new bone in between the shield and the implant. Just to summarize my presentation, I hope I took you in a very big journey from 2004. So as you see, from the mid-70s until now, a lot of protocols have been changed. We made so many mistakes. We had so many complications that we, at that time, defined it as complications. And then we found, as we read more and climb in our learning curve, we find that those were not complications. Those were real mistakes that we made unintentionally. But after all the research now, we know what should be done. Now we know what should be done. That's very important. We have to evaluate the risk and judge the predictability of the immediate implantation. It's not easy. We should check the integrity of the socket. We should define when to do and when not to do. And this is the most important thing. We can plan everything. I will summarize my final recipe. It will be 10 points. Take your cameras and take the slides. I have 10 ingredients that I showed you for your success. First, atraumatic extraction, preserve the buccal plate, check buccal plate integrity. The most important is that the 3D implant positioning, now we are placing deeper and more palatal. We should use narrow implants, never use wide implants. In immediate implantation in the aesthetic zone, never. The maximum is 3.75. This is the maximum. I usually place between 3.2 and 3.5. I would prefer that. 3.75 is the maintain the adjacent proximal bone integrity. I said, keep 1.5 millimeter away from the adjacent bone just to maintain your papillas. Always graft the gap buccal to the implant. Always make a provisional temporization or a custom healing abutment to cover, to maintain your soft tissues, and consider socket shield therapy when indicated. So we all need a learning curve, as you saw. As we climb up in our learning curve, we realize our mistakes, and we should always know that taking our new knowledge, it's not from Facebook, it's not from YouTube. Those are informative, they are not educational. Please, I always tell my students, how can you go onto YouTube, on Instagram, just make a video or see a video, and next day you want to apply it on a patient's mouth? This is nonsense. You go for training courses. Reader, with a lot of other academies, they have excellent courses. One of them is the hands-on advanced on patient advanced course, which is done with the University of Sarajevo. You'll get a lot of complicated cases, and we have courses, education as well as fun. We have fun all together during those courses. I'll be more than happy. It's not only me, a bunch of excellent, super excellent mentors. My colleagues, super excellent mentors who can shoulder teaching, one-to-one mentor. A lot of fun. We enjoy every moment. My take-home message for you, please. We all make mistakes, but we learn from our mistakes. But the most important thing is that, as Thomas Edison said, If we make mistakes, never repeat our mistakes. And this is the curve of learning. Thank you so much. This is, thank you. This is a view on my boat from my city in Syria. Very beautiful city on the Mediterranean. If you want to contact me, this is my contact. Any question, I'm ready to answer now, and we can start our hands-on course. So, the recipe is 10 ingredients, right? We have to apply them now on the model. Okay? We have to apply the 10 ingredients that I gave you on the model. Yes, sure. Okay. This is a model. Our implant to be inserted is a 3.75. This is 13. Okay? 3.75, 13. So we will do the drilling with the reader implant system accordingly. Okay? So it's very clear that you are all experts in implants. I'm not, okay. So you know, but the main thing I want, the recommendation, is that I want to see all your implants are 2 millimeters minimum away from the buccal plate. And I showed you how. We place our pilot drill or the lance drill. The first, I will show you. The first lance drill, I'll show each of you. Please, wait. We go in the 35 degrees first in the buccal, down for 5 millimeters, in the, in the palatal, okay? With the 35 degrees. Then after we don't go this way in the socket, okay? We go palatal, palatal for 5 millimeters, and then, okay? You see? I place it here. I pressed it with my hand. Okay? Now, I go this way.
Like this, yeah?
Yeah.
Then?
No. It's not this. Wait. Don't drill. Let me show you. You go here.
Yeah.
2 to 3 millimeters buccal. Go. Drill. Okay? You go for 2 to 3 millimeters, and then you
Then change, yeah.
Yeah. Okay? So, this is very important. This is how you maintain your preparation site in a way that you insert the implant away 2 to 3 millimeters away from. Yes, correct. Then, with this, you go this way. You see? From the same insertion. Okay? Wait. It's here. It's not in the depth of the socket. No, it's here. Okay? You go for 2. Come on, drill it. 2 millimeter. Now. So it doesn't slip. Okay. Okay? No. After the pilot drill, it's done. You go just like this. The first drill, wait, please. The lance drill and the pilot drill, they are the one who will go at the 35 degrees in the palatal and then make it parallel. Afterwards, all the other drills, you go directly in your direction. Okay? So you have made the way. You have already made the way for your drill.
I think it's good.
Yes, correct. You see? This is how the final result should be, okay? Even though I go this way, it's not this way, it's this way. So, the socket is never your direction. The socket is never your guide. You go palatal first for 3 to 4 millimeters, and then you take your second drill. No. This one will be touching. Don't go all the way like this. You went like this, and then you should go this way. Okay? This is the position. You got the point? So, when you insert your implant, it will stay, all the labial threads of the implant will stay 2 to 3 millimeters away from the buccal plate. Of course, this only applies in immediate implantation, okay? Your model?
Yeah, that's his model.
Whose model is that?
You stole mine.
I stole yours?
You stole my model.
Ah, okay. Now, this is good. 2 millimeters deeper than the crest. This is the correct 3-dimensional positioning. 2 millimeters depth subcrestal. 2 to 3 millimeters away from the buccal plate, and always use a temporary abutment. Don't you ever put a cover screw and try to suture. This will not work, okay? So always you have to maintain the soft tissues. Keep it as is by either fabricating a custom-made temporary abutment or use a ready-made abutment that fits the size. Okay?
Now we need to put this.
That is perfect. That is the perfect one.
Give that model to me.
That is the perfect 3D positioning for immediate implantation. Okay? Now, what do we do with this gap, I said? We have to graft it, right? No graft? Yes. This sponge, there are graft materials which are a mixture of collagen and beta-tricalcium phosphate or whatever. They come like a... We are not using now the original. You can use the powder, allograft material mixed with saline, and you pack. But before you pack, you have to cover the implant with the cover screw.
Before it.
Okay? Listen to me just carefully, please. Before you place your bone graft material, place the cover screw, then pack your material, then you take out the cover screw and place the healing abutment. Okay? Now, let's take this bone graft material. Okay. You have the sponge, right? Okay. We can pack it easily. Yeah.
Now.
No, it's bouncing. If we have some water. Yeah. We can just place it here.
Insert one, sir.
Yes. And you can insert it as a powder.
Forceps.
Yeah, or a forceps. But we don't have a forceps here. Yeah. This will...
It's good?
Yes, perfect. Now, you take the cover screw out and you place your gingival former. Okay? Yeah. Now you can easily pack your material. Okay?
Okay.
Use this. Done? You're an expert. This is to be a great expert. Wow.
No.
Yeah. Now, this is a little bit more palatal. Yeah, but it's okay. Little bit. Now you can place your, put your cover screw, or then place your graft material. You can dip this a little bit in water. You see?
One question.
Yeah, perfect. That's awesome.
Do I need to put
That's
bigger
awesome.
one to close the hole?
Yes.
Yeah.
Yes.
We need to close the hole, yeah?
Exactly. We have, after we place our graft material, we have to cover all the area by placing a temporary crown that goes exactly with the contour. If we are not able to fabricating a temporary crown because our insertion torque did not reach the level of temporization, we just place a customized temporary healing abutment that goes, that covers, protect all the graft material, keeping the soft tissues away, letting the bone only that grow into the socket. Okay?
Customize the healing abutment.
Yes.
You can use composite to customize.
Yes. But there are special
Abutment.
yes, abutments.
Wider.
Yes. It's not wider. It depends on the size.
One question about one abutment one time. You, when place the abutment, when you place the implant, then don't remove the abutment when you take impression.
No.
So you take impression like if was a natural tooth.
No. Actually, I put my impression and impression copy before I place my abutment. Okay?
But I mean,
I take a final
after
impression.
3 months. After
After 3 months,
remove the abutment.
yeah, you can even remove, or in this case, I took my impression even before putting the final abutment that I have. Okay? I took the impression, then put my final, fabricate and close. Now I have the impression with the direction of the implant. Then with the intraoral scanner, I just make a small modification on the gingival line because it may change a little bit, and then I fabricate the final.
So you can leave the temporary abutment
for
in the,
3 months. Yes.
Okay, but when you take impression, you will do a copy of temporary abutment because
Exactly.
you leave the provisional crown.
Yes.
Okay.
Got the point? This is awesome. Yeah. The only thing that I have to show you, which is we cannot do it here, is the custom healing abutment. Either you choose a bigger. There are a lot of cases with. That is perfect.
Thank you.
You see, I want to show you just one hint. Look at the curvature. If we drew a curve here, this comes exactly at the center line
Repeat.
Yeah. If we draw a curve here,
Tá dando meu exemplo, do meu modelo como exemplo. Dá uma
yes,
olhada.
exactly. It will, this axis will fall exactly on the curved line here. Okay?
Thank you. Finish.
If you finish, yes. Perfect. Perfecto. Very well done. I guess. Finish. So, don't forget the recipe. You took your slides. 10 points. 10 ingredients for a lovely recipe. You will succeed always. Okay?
It don't depend what kind of graft you put here.
So, in fresh extraction socket, I will prefer the allograft. But the allograft is not available, let's say, in Europe. Okay? So you can go for better, you can